kind introductions. Good afternoon. It is my honor to participate in this wonderful symposium and communicate with immunogenetics people like you. Unfortunately, I won't touch the detailed immunogenetic aspect. Instead, as a transplant nephrologist, I would overview the growth strategies against sensitizations. The ESKD instance in Asia, including Korea and Thailand, is very high. The more serious problem is the very high speed of increasing incidence in most of the Asian countries, including Thailand and Korea, number 1 and number 2. Therefore, the deceased donor transplant program is not so active compared with the Western countries. The discrepancy between needs and supply in organ transplantations have been aggravated more and more. So this is a big problem. Currently, there are two most important hurdles in Asian transplantation field. The first one is donor shortage. The second is the insufficient efficacy and safety of current immune suppressant. In respect of donor shortage, in addition to the activation of deceased donor transplant program and the cutting-edge xenotransplant works, so we could try desensitizations for APHIA incompatible or APHIA HLA incompatible living donor kidney transplantation, or we can try desensitization for highly sensitized wait-risk patient for deceased donor transplantation. For second, the prevention and early detection and treatment of antibody-mediated rejection is essential. The first topics deal with the secondary immune response, and the second topics deals with the primary immune response. As you can see here, the high PRA or positive PRA increased the waiting time. As you can see here, the high sensitizations decreased the opportunity of deceased donor transplantations. In this Korean national study, the positive PRA has a significant lower chance of dedicated opportunity. Actually, median time is over 10 years. This is a serious problem in many Asian countries where the donation rate is very low. Of course, the highly sensitizations decrease the dedicated chance to more. Unfortunately, there is also inequality in dedicated opportunity among ABO blood group, because there is the first priority in HLA full match and regional priority. In those cases, ABO compatible transplantation is permissible instead of ABO identical transplantation. If we combine PRA and ABO blood type, we can classify 4 groups according to chance of dedicated. In contrast, the performance, the outcome of dedicated is similar among the 4 categories. So we should minimize this unacceptable inequality according to sensitization. So we are changing registration to provide more benefit according to the chance of kidney transplantation, likely exponential the values to highly sensitized patients. To overcome the aggravating the discrepancy between need and supply, we have activated high-risk kidney transplantation after desensitizations. ABO incompatible transplantations increased steadily, now reached between 25 to 30% of living donor transplantation. As you can see here, the percentage of the HLA incompatible transplantation, including Immunogenetics positive alone, reaches around 10%. So There are various anti-humoral treatments have been used for desensitization or treatment of antibody-mediated rejection. We can inhibit the B-T interaction, so we can induce apoptosis of B cells and plasma cells. Or we can mechanically remove antibody or degrade using immunipidase. And finally, we can interrupt the interaction with the antibody and complement and endothelial cells. The inhibition of cytokines and growth factors, the importance of B cell is another strategy for desensitization or the treatment of antibody-mediated rejections. Desensitizations removes the preformed DSA and induce the killing of DSA-producing cells in order to prevent rejections. There are the hierarchy of HLA-incompatible LDKT according to strength of DSA. As you know, the CDC cross-match positive has strongest DSA levels, and then the flow positive and the donor-specific antibody alone has the weakest antibodies. When you analyze the HLA-incompatible living donor transplantation result, it is very important to set the appropriate competitor for HLA-I-LDKT. HLA-compatible LDKT is not the good comparator control group for HLA-incompatible LDKT because these candidates do not have this kind of compatible LDKT. This the reason why they choose incompatible LDKT. How about HLA-compatible DDKT? It's not fair because we should long time to get this DDKT. So the combination of HLA-compatible DDKT plus wait-listed patient could be the appropriate competitor for HLA-I-LDKT. In some countries with a very active donor exchange program, then we had better combine the three groups, HLA-compatible DDKT and the donor exchange living donor transplantation and wait-listed patient. I would like to introduce the several strategies of desensitization. The plasmapheresis and IVIGG, the combination has been used as a standard of care for many years. The high-dose IVIGG alone gave the inferior outcomes compared to the plasmapheresis with the low-dose IVIGG. Tocilizumab, anti-IL-6 receptor antibody with high-dose IVIGG have been successful in refractory cases of desensitizations. And B-cell depletions usually are combined with standard of care. Rituximab is chimeric antibody, and obinutuzumab is humanized antibodies. Humanized antibody deplete B cells in lymph node better than rituximab, but overall the outcomes, there was no difference. Second, plasma cell is actually the cells to produce DSA directly. So proteasome inhibitor like bortezomib has been tried to desensitize. After bortezomib, new generation of proteasome inhibitor like the capizumab, irreversible inhibitor, and the ixazomib is oral agent have been tried to desensitize patient. And recently, anti-CD38 monoclonal antibody like daratumumab has been tried to desensitize or treat antibody-mediated rejection because CD38 is expressed on late stage of memory B cells and plasma cells. The weak point of bortezomib therapy is that they cannot deplete the plasma cell in bone marrow niche, or the germinal center, the B cells compensate for the loss of plasma cells. So Chicago group combined the bortezomib with the belatacept to diminish the germinal center compensation. This is another good approach to desensitize patient. The third approach is terminal complement inhibition. So eculizumab has been tried to desensitize as a supplementary agent in combination with the plasmapheresis or high-dose IVIG. They reduce the incidence of ABMR. C1 esterase inhibitor, the class pathway inhibitor also has been tried, but the result is not so good yet. Imlifidase, as previous speakers introduced, they can degrade the antibody directly in a short time, but rebound is the weak point, and then we cannot use imlifidase in the treatment of antibody-mediated rejection. We can only try in the desensitization for short-term period, especially DDKT. So this figure shows our desensitization protocol. We give the rituximab 1 week before plasmapheresis and give plasmapheresis according to the strength of preformed DSA, and then adjust the number of plasmapheresis according to the follow-up titer. Of course, we give thymoglobulin and give the bacterium ganciclovir to prevent opportunistic infections. As you can see here, the graft loss rate is proportional to the DSA strength. This, the US multi-center trial shows that desensitization, actually incompatible LDKT after desensitization, shows the better outcomes compared to dialysis alone or DDKT or the wait-list patient. The survivor benefit was common across all strengths of DSA, CDC positive, flow positive, or Luminex alone. However, in the British study, the survival benefit of HLA incompatible transplantations lost compared to the wait-list patient or DDKT. Maybe because the dialysis outcomes much better in United Kingdom compared to United States, and they also included living donor transplantation using donor exchange program. So the control group has a better outcomes compared to US problem. How about in Asia? In Korea, as you can expect, the waiting time is much longer than in Western country. Therefore, the survival benefit of HLA LDKT is quite bigger than the waitlist patient or DDKT. The survival benefit is common across all range of DSA strengths, CDC, flow positive, and DSA alone. Next, we try to test a lot of complement inhibitor in desensitization using mouse model as first step. We transplanted human blood group A transgenic mice heart to sensitize the allogenic recipient and give triple common immunosuppressants, steroid, tacrolimus, and mycophenolate without C5 inhibitor. As you can see here, conventional triple immunosuppression could not inhibit the antibody-mediated rejection, actually mixed rejection. However, combination of anti-C5 inhibitor induced long-term survival and suppression of antibody-mediated rejection and T-cell mediated rejection simultaneously. Based on this animal experiment, we tried C5 inhibitor eculizumab in combination of plasmapheresis and high-dose IVIG to sensitize the patient, especially refractory with very high, unacceptably high anti-ABO titers, despite the numerous times of plasmapheresis and IVIG. The first patient final titer before transplantation is 128, despite of this multiple session of plasmapheresis. So we gave the eculizumab for 4 weeks. In second patient, we gave eculizumab for 2 weeks because accommodation usually appears in about 2 or 4 weeks in APHIA incompatible transplantation. We thought the short-term ecruzimab therapy is enough for desensitization in ABO in contrast to the HLA incompatible transplantation. Actually, the second case is simultaneously ABO incompatible and HLA incompatible. But the final DSA titer is about 2,000, MFI is about 2,000. As you can see here, unfortunately, the first patient has early sign of ABMR despite in the middle of ecruzimab. So we combined plasma pheresis together with the ecruzimab. And then her course is very good. The antibody titer is decreasing and creatinine level is maintained very good. In second patient, there is no sign of ABMR, and she can keep her renal function at good status. So I would recommend try the ecruzimab for the patient with unacceptable high ABO titer or HLA titer despite multiple sessions of plasma pheresis. I think imlifidase is another good choice because ABOI has accommodations. Just a short course of imlifidase is enough for IgG. For IgM, you can combine plasma pheresis. We can easily remove IgM anti-ABO because they reside mostly in intravascular space. For how about the deceased donor transplantation? In this trial, we included the highly sensitized patient who have waited for longer than 4 years. They have a history of failure to receive kidney allocation due to cross-match positive and high PRA. We used the simple regimen, 2 courses of high-dose IVIG and sequential therapy of rituximab and bortezomib. If you fail to receive kidney transplantation within 6 months, you may repeat this protocol. By this protocol, we increased the transplantation opportunity statistically significantly controlled compared to control. And actually, DSA titer a little bit decreased. The second regimen is a combination of plasma pheresis with the first regimen, and we didn't publish the second regimen, but my gut feeling is the second protocol is more effective than first protocols. This is our protocol for desensitization in ABO incompatible transplantation, quite similar as HLA incompatible transplantation, but we gave basilizumab instead of ATG. The ABMR risk is lower than the HLA incompatible one. This Korean data shows the outcome of graft survival is similar between ABO compatible and incompatible. And it is more important to compare ABO incompatible transplantation with waitlist patient or the ABO compatible DDKT. As you can see here, the survival benefit of ABO incompatible LDKT has definite survival benefit compared to waiting list and ABO compatible DDKT. The long waiting time must have contributed to this big difference. Let's move to the second topic, how to overcome the current insufficient efficacy of current immunosuppressions. As you can see here, the chronic rejection is the #1 cause of graft loss in the long term. And then antibody-mediated rejection is the most common diagnostic entity 1 year after transplantation. So if we combine these 2 figures, the chronic antibody-mediated rejection is the most important hurdle for the insufficient efficacy. How to solve this problem? Unfortunately, current treatment for chronic ABMR are disappointing. There is no proven efficacy of plasma pheresis, IVIG, rituximab, or ecruzimab for chronic antibody-mediated rejections. So expert opinions usually recommend optimizing maintenance immunosuppression, such as increasing the tacrolimus levels or adding steroid in steroid-sparing regimen, and so on. And then PRN, we can combine high-dose IVIG. This is the evidence-based recommendations. However, there are ongoing new trials to treat chronic antibody-mediated rejections. Tocilizumab and clazakizumab is anti-IL-6 therapy, and tocilizumab have shown some success to decrease antibody levels and delay the graft loss. However, the international trial of clazakizumab imaging studies unfortunately failed to replicate their early success. Second, now the new trials are moving from the B-cell therapy to plasma therapy. So anti-CD28 monoclonal antibody like daratumumab or anti-BCMA antibody. Anti-BCMA antibody, BCMA expression is also appears memory cell and plasma cell. And the combination of bortezomib and cosmetic blockade is another way to reduce the plasma cell and DSA. And another promising candidate is neuronal FC receptor. This is another the new promising therapy because this is a lacks anti-drug antibody response in contrast to imlifidase. These humanized antibodies are more promising than the imlifidase. However, the performance of treatment is poor. It is more important to prevent and detect early of donor-specific de novo DSA and antibody-mediated rejection. Of course, APHIA mismatch and monitoring-based adjustment individualized immune suppression is important according to the sophisticated immunogenic technique, DSA levels, cell-free DNA, and so on. Of course, we should avoid suboptimal immune suppression by monitoring tacrolimus inter-individual variability or the pharmacogenetics tests like left metabolism is more common in Asian countries. And of course, we should control early T-cell mediated rejections completely because the early T-cell mediated rejection usually precede the late chronic antibody mediated rejections. Let me finish my talk by this summary. Sensitization is an important hurdle for successful transplantation. HLA-incompatible living donor transplantation is an important strategy to expand the donor pool, especially in Asian countries where disease donation rate is very low. Of course, HLA-LDKT has worse outcomes than HLA-compatible LDKT. However, they showed better outcomes than HLA-compatible DDKT or the dialysis. DDKT after desensitization in highly sensitized wait-list patient is another fascinating approach to increase the transplantation opportunity with acceptable outcomes. Desensitization protocols use various anti-humoral therapies such as classically plasmapheresis and IVIG, and in combination of rituximab, bortezomib, ecrolimus, and imlifidase and other plasma cell targeting agent. Thank you very much for your attention.
Thank you for your talks. Are there any? Yes, please.
Thank you. That was a great talk, thank you. I noticed on your slides that for your desensitization patients, you're giving prophylactic Bactrim and acyclovir. Do you see many infections in patients undergoing desensitization, or does the prophylaxis mostly protect them?
Are you talking about specifically for ecrolimus cases?
Just any kidney recipients who are undergoing desensitization.
Yeah, of course, there are a little higher chance of infection rate. So we should balance the risk of infection and mortality during dialysis waiting list. So overall, the the patient survival curve in USA and UK and Korea shows the overall benefit exists between HLA incompatible and dialysis or the HLA compatible dedicated. I agree with the infection risk is higher, so it is important to implement the prophylactic, adequate prophylactic regimen, especially the viral infection. And then we should avoid the over-immunosuppression using the monitoring tools. But overall, the dialysis mortality is very high, so we would recommend incompatible transplantations.
Thank you very much.
You mentioned a little bit about the pair exchange program. I remember that Korea is one of the leading countries doing that. Can you update me on the pair exchange program in Korea?
Yeah, actually, Korea is the first country to introduce the donor exchange program. So it takes about 4 months to succeed in donor exchange in old days, but after introduction of APHIA incompatible transplant program in 2008, donor exchange program became very weakened. So if we exclude APHIA incompatible persons, the number of HLA incompatible, the sensitized patient population is small. Compared to the USA, the population size of Korea is small, so it's actually difficult to exchange among only DSA positive, highly sensitized rabies patient. So unfortunately, donor exchange program is now very inactivated in Korea. We should reactivate those programs. I agree with you.
Thank you so much for your presentation. Actually, I would like to know for ABO incompatible transplantation, we are faced with complement activation, right? So how could you manage the complement activation there? And also in the biopsy, we will see the C40 positive. So how could you manage it?
After transplantation, are you talking about the anti-immunosuppressive therapy after ABO incompatible transplantation, or are you talking about the desensitization strategies?
No, before the transplantation.
Before the transplantation. The basic protocol is plasmapheresis without the low dose IV immunoglobulin. So plasmapheresis or the immunoadoptions in European countries to decrease the anti-ABO titer to acceptable level in most cases. But sometimes we experience unacceptably high. In this case, we can try imlifidase or ecruzumab as in my case series. So I think I would recommend the basic protocol is plasmapheresis without low-dose immunoglobulin and rituximab. And second approach is the rescue regimen is imlifidase or ecruzumab is a good rescue therapy.
And my second question regarding the plasmapheresis. Actually, I don't know how could you use it and for which kind of the patient, but I know that during the plasmapheresis, you remove the other antibodies also, right? And the patient will be risk on the infection.
Yeah.
But most of the nephrologists try to use the plasmapheresis, but we will see that death of the patient after the plasmapheresis. How could you manage it in Korea?
Yeah, I'd like to show our protocol. So, yeah, the weak point of a conventional plasmapheresis is the removal of the irrelevant protective antibodies. So it is important to keep a adequate prophylactic regimen using such as Bactrim and ganciclovir, and for sometimes INA or for the latent tuberculosis. So infection risk of especially PJP is higher in ABO incompatible transplantation compared to ABO compatible. So there is no the fascinating rule to avoid the infection risk completely, but the infection risk is, I think, manageable by prophylaxis and the sequential monitoring and early treatment. The replacement of IV IgG may be another way to lessen the infection risk. But as far as I experienced, the infection risk of the ABO incompatible transplantation is much lower compared to the ABO incompatible transplantation, because the number of plasmapheresis or the intensity of maintenance immune suppression, the induction agent, we use just the Bhumisiri in ABOI in contrast to the HLA-I, where we use ATG. So strength of immune suppression is a little bit weaker in ABOI. So infection risk is weaker than HLA incompatible transplantation.
Thank you.
And then the accommodation phenomenon make us to reduce immune suppression around about 3 to 4 weeks later. Then we can reduce the immune suppression.
Thank you for sharing with the ABO titer that your center used. But would you please share more about the method that you use in your center for ABO titration?
Yeah. Initially, I moved to another center. In the first center, I used the jail card method because there is less inter-individual variation. But the second hospital, we just use the cell line tube test. I think in most cases, the cell line tube test is enough if the operator is experienced one. But I would emphasize the anti-ABO titer in blood using RBC does not necessarily represent anti-ABO titer or antigen intensity in the endothelial cells. Although the titer is low, but we can sometimes experience a strong ABMR and thrombotic microangiopathy. So we need to improve our anti-ABO test. So Japanese colleagues, for example, University of Niigata, they use the CD31. They measured the anti-ABO titer against the anti-ABO antigen on the CD31, the endothelial antigen PCAM, and the University of Alberta, Lord West group developed the Luminex anti-ABO kit, but we will see their utility. But nowadays we are using J-card or cell line tube test. Most cases it works very well.
Thank you. I have one more question, last question. Would you please share about your plasma exchange program? Do you use just TPE or the FPP or antigen-specific immunogenicity?
Yeah, that's a good question. TFPP is popular in Japan. I guess it's also popular in Thailand, but insurance company doesn't reimburse, our government doesn't reimburse the TFPP. So most cases we use conventional plasmapheresis, but hemodynamic unstable patient we use TFPP because replacement of fluid is very small.
Thank you.
Okay, thank you so much for Professor Yang. Please have him a big hand.